We're still learning more about the Delta variant every day, how contagious it is, how deadly it is for the unvaccinated, and what we can do to prevent it from wreaking further havoc. We've heard your concerns and questions, and today I'm going to be addressing them with a doctor who has so much information. I'm excited to bring him to you. I first want to say this. We know vaccinations are extremely effective, as in they almost always prevent death and hospitalization from COVID 19. I'm vaccinated, and here's a reminder to you, please get vaccinated if you haven't already. But there's still a lot we don't know about the Delta variant, and here to shed light on the latest numbers and data is Dr. Jeremy Faust. He is an ER physician at Brigham and Women's Hospital and an instructor at Harvard Medical School. He also has a newsletter called Inside Medicine that's full of useful information. Dr. Faust, thank you so much for your time.
Great to be here.
I want to just say this so that everyone knows you have a huge fan base among very smart doctors who look to you for their information. So I'm glad that we're able to get access to you directly. First, I wanted to ask if we could speak sort of to the vaccinated. A lot of this audience is vaccinated, but they're very worried about how they should be changing their behavior right now. So some specific questions, just should people stop indoor dining? Should we be wearing masks when we go to outdoor gatherings? What should you do if you're the parent of an unvaccinated child or live with someone immunocompromised?
Those are all really complicated questions, and let's just dig in. So Delta has changed my personal behavior. Everything is all about risk tolerance. One person has a high risk tolerance, one has a low, but it changed my risk tolerance in my behavior in some ways. And I'll give you some specific examples. I, for example, was not really worried about getting any rapid testing on myself after exposure up until about a week or two ago. And now that I've seen the data on Delta, when I feel that I have gone through a high populated area, or if I had a known exposure to somebody, I feel the need to get tested in a way that I did not feel a month ago. So that's a big change in terms of how I'm managing my own behavior. In terms of masking, I think that the CDC was very wise to color code this. They actually had never really done this, to say a certain intervention should be tied to the situation on the ground. And that can get real messy because people can't hear 10 messages at once. But I think it's worth it, because if you're truly in an area with low case counts and low hospitalizations, and then I think that you deserve a break, right? You should be able to do stuff. And I certainly did that in June, for example, in Massachusetts, and I went to New York a couple of times. I felt that there was a window there. But when the cases spike and they go higher and the CDC's laid out specifics, then yeah, in those areas, those hot spots, then I'm putting the mask back on. I'm limiting my indoor dining. I haven't eliminated it, but I'm picking my spots, if you will. So I'm no longer sort of, okay, it's free out here. I'm now sort of picking my spots.
So if you're living in one of the hotspot zones, what's your view of sort of going to a large outdoor gathering?
Okay, so large outdoor gatherings will depend. I think that we saw, for example, with last year with the George Floyd protests, those did not cause super spreader. Why? Because people were pretty far apart. They were wearing masks. And they probably didn't even need to in some cases, and they weren't destinations. They were staying home. They went to wherever the protest was, and then they went home. Compare that to like the Sturgis bike rally, which is also kind of distantly outdoors. They're outdoors on their bikes, but big spike there because people came from afar. They have to dine indoors. They have to go through the hotel lobbies. No one's masking. So it's all about the stuff around the event that matters. And it matters also the extent of the density. So if you're in a pool party, it's like, yeah, everyone's moving around. But if you're the picture that I tweeted of Lollapalooza, where it just looks like, a stampede, I'm thinking, yeah, that's not exactly what we meant when we said that outdoors was relatively safe.
Okay, that's helpful. What if you live with somebody who's unvaccinated?
Live with someone who's unvaccinated. The question being, what should you do in terms of masking or?
Yes, like how should you change your own behavior if you're a parent of an unvaccinated young child? How do you keep them safe?
Well, the number one way I'm keeping my unvaccinated kids safe, for example, is essentially to limit the shots on goal. There's some things that we're just not going to eliminate, right? I'm going to send my kid to school if there's testing. I'm going to do certain things, but I am not at this point going to the indoor 5,000 person thing that I was thinking of doing. So I'm basically realizing that the more exposures I have, the more likely I have a breakthrough, the more likely I spread it to my daughter. And so basically it's situational because every single situation is different. There's how many people are there? Are they masking? What's the ventilation? How long am I there for? Have they tested in this place? Is this a highly vaccinated place? So pretty soon the number of variables are infinite. And so I take each situation as it comes, which is like totally useless for your viewers. But the top line message is that a month or two ago, I really wasn't thinking about this.
I think it's helpful for us to hear how you think about it so that we can start to internalize asking those kinds of questions ourselves. You've written this, quote, "My personal belief is that a great deal of coronavirus spread comes from a relatively small subset of highly contagious cases. If our vaccines continue to render the most contagious cases less so, it might mean that breakthrough Delta is not really as contagious as unvaccinated cases are." Do we know the answer to this question yet? Are vaccinated less likely to be infected with Delta than the unvaccinated?
Yeah, I wrote that last week, which was a year ago. And, and actually it's, but we can answer a lot more now. And I stand by everything there. I do really, truly believe that there is that the average person is not the average spreader. The spreaders are really in this subset of people who have a high viral load. And it could be that they have a high viral load for one day. It could be that all of us have the super spreader potential for 10 hours during our course, or some people have it for 2 days during their course. And so there's the super spreader individuals and there's super spreader times. And the data are really beginning to show this. So for example, all this new data. So the first question is, if you're vaccinated, are you less likely to get infected, right? That's your first question, right? With Delta. So certainly in the pre-Delta era, you were far less likely to get infected with anything, asymptomatic, symptomatic infection, symptomatic disease, but even just infection, right? It was like 90% less in some of the data sets. The Delta variant is changing that in the wrong direction, but it's still protecting against infection a lot. And I was just debating this today with a colleague, like what's the number we should use? And I'm pretty comfortable with kind of a ballpark. So before Delta, I was thinking, if you get exposed to the virus, you're 90% better off than you would be if you didn't have the vaccine. Today, I would say it's about 75%, 70%, somewhere in that realm. So you're still highly protected against infection, but instead of a tenfold difference, it's kind of a threefold difference. And then the question is, from there, what happens, right, in terms of contagion, forward spread, right? And that's another thing that we've learned about in the past couple of days. And it turns out that we're now beginning to see data that say early on in the officials' ability to detect all of this, the viral loads are about the same between unvaxxed and vaxxed Delta, right? That was the thing that led me to write that, was that if you're infected, you're now as contagious whether you're vaccinated or not. And that was based on the fact that the viral load, the amount of virus in your nasal passages and your airways, were about the same either way. The question that we're now getting a little more data on is, how long is that true for? And the good news is that the vaccinated folks have a shorter window of that. So, but it's good news, and it's not as good as I wanted it to be. So there, in the unvaxxed folks, there's like about 10 days of this period where you could be pretty contagious. It looks like in the vaxxed folks, it's like more like 7. So that's a huge difference on a population level, but not what we had before, which was like 2 or 3 days. With Alpha, when you had a breakthrough, it was like just a couple of days of contagion, if anything. So that's the part that I think really kind of like took me aback, that it's like, oh, wow, this can be spread forward.
Significantly. Okay, that's really helpful. What makes a breakthrough infection more likely? Are masks just as effective against Delta?
Okay, that we don't know. I have a personal belief, which is that the masks are helpful in some degree for all of this, but that Delta being more contagious just makes the mask a little less of a good goaltender. So I think that masks have essentially eliminated influenza last year and all the other mitigation, but it did not eliminate COVID, it decreased it. I think that Delta makes masks in one way more important, but on the other way, not foolproof, right? So we don't know the answer to that, and I would like to see data.
Let's talk for a minute about what we don't know. As a country, we are not doing mass testing. There's no required reporting. If I do a home COVID test and I test positive, I'm not required to tell the CDC. Also, there's a lot of asymptomatic COVID, presumably, especially among the vaccinated. So it would seem that we wouldn't really have a clear picture of how much infection there is in this country. I'm wondering if you agree with that and why we're seeing these reports that say breakthrough infections are rare. Can we really know that right now?
Yes. So when the CDC stopped testing everybody in the sort of vaccine era, there was an outcry. Oh, we can't track it. And I kind of felt like, yeah, it kind of makes sense. All they care about is hospitalizations. But now with Delta, we're back to where we need to be able to track it. So I think that testing now becomes more important so we can track this. In a vaccinated population, whatever percentage it's going to be, 80%, 50%, the amount of hospitalizations really is what tells you what's going on. Because in a way, it's sort of like the Goldilocks, the kind of perfect, right? So case counts are just too many, meaningless. We don't know if they're asymptomatic, mild, like who really cares if this vaccine has rendered coronavirus into kind of a seasonal flu, okay? Like, okay, it's not that bad. On the other hand, if you have a situation where the hospital, you're only following deaths, that's actually kind of rare and you might not know soon enough. So I like hospitalizations because it kind of gives you a sense of like, wait, how sick are folks getting with this? And maybe in time to do something about it. So I think that the number one metric that I'm really watching is overall hospitalizations in any community, and then this breakdown of vaccinated versus unvaccinated. The last thing you mentioned was, can we really say it's rare? And I'm actually writing one about this right now. And it's so true that it's rare, and it's such a bad idea to say that because it's going to become less rare. And then the people who heard that are going to say, but you said it was rare. And the reality is it's going to become less rare for a couple of different reasons. One is as a percentage of the cases, the more vaccinated people you get, actually overall hospitalizations come down, but the representation from the vaccinated group is actually a bigger piece of the pie. But also with Delta, we're seeing just an uptick in hospitalizations in general. So I think that in the end, vaccination becomes even more important, even though the efficacy comes down just a bit, because Delta is kind of a beast. It really does seem to drive case counts, hospitalizations, and maybe, hopefully not, but maybe deaths up as well.
Isn't there also a piece of this, though, that we need to take this seriously and adjust our behavior even if we are vaccinated? And I know anecdotal evidence is not data, and we have to look at the data. That said, given the lack of testing right now, I do hear from so many people who have had breakthrough cases and they feel terrible, like really awful for weeks, and they don't want to get it. And so is part of the message we need to be sharing, or that our health officials need to share, is even if you're vaccinated, this is a potential risk to you. You do need to mask and think about changing your behavior, or no?
Yeah, I think that to some degree you could have the nihilist perspective saying, look, we've got a vaccine and that's the best we're ever going to get. We took the number of deaths, hospitalizations, and divided by 10 or 20. And look, guys, we have to move on. But I think that there's a couple of reasons why that's inadequate. One is there are people, immune compromised people, older people who probably need a booster at some point. We don't know about the rest of the population, and even that is not settled. There's also, I really do think, as you said, it's worth avoiding this virus. A so-called mild case of SARS-CoV-2 coronavirus can be not fun. You can have the loss of smell, the loss of taste, fever for a week, body aches, and be totally out of commission in your home. And that's mild. So it really only becomes serious, severe, critical when you have oxygen requirements, where you actually need to be on oxygen. So yeah, I think it is a virus that's worth avoiding for sick days, for your own, whatever. We don't even know about the long-term stuff with vaccine. We don't know. It's worth for not spreading to others. And so for me, this is where I sort of come back to, for the first time since the vaccine really rolled out, I actually think it's now worth considering a sort of massive testing regimen to be rolled out.
I'm going to ask you about testing right now. I just want to underscore this, something you mentioned. We don't know whether long COVID can happen to people who get breakthrough.
We don't know that because it's all sort of new. I think, and also even sort of long COVID 1.0 is a very undetermined thing. I think that there's a big, huge portion of it that is long-term viral stuff. The virus has wreaked havoc. And there's also a piece of it, which is PTSD, which can have physical manifestations. You can actually have genuine physical symptoms from PTSD. And I think that, it makes sort of total sense. If your parent died and then you had a mild infection, you're going to tell me that that's not going to have an effect on your body? Of course it is. So we don't know really what's going on with long COVID yet, 1.0. And with 2.0, I think, and with vaccines, it's I'm way not ready to talk about it.
Let's talk about testing. You've written that, quote, "I believe there's no money better spent than on tests, especially rapid tests that provide reliable and actionable information in minutes, not hours or days." Now, we all know that these rapid tests, or we've all heard these rapid tests, can present false negatives. But would you explain why they're a very useful measure of contagiousness and why we should be using them?
Yes, I'll start with the second question. They're a great measure of contagiousness because rapid antigen tests detect basically a protein of the virus that's only detectable when there's really infectious virus in your face. So if I do a genetic test, I can get the genetic material from your virus, and that could be weeks old, and it could mean you're not contagious. You're not really doing. It's just like shrapnel or fingerprints.
That's the PCR test.
That's the PCR test. Whereas the antigen test only picks up a protein that basically vanishes once you're no longer contagious. So what's so huge about that is it tells you that you're contagious right now. And there's actually been a little bit of a misnomer in calling some of these tests false negatives, because the rapid antigen test is not falsely negative if you have a very early infection that's not yet contagious or a very late infection that's no longer contagious. It should be negative at those times because you're not contagious. It seems to be almost always right in that contagious window. And so if you just want to stop spreading this virus, if you're negative twice, I think that you should do it twice. If you're negative twice, you are not contagious right now, right? And so that to me, it's not falsely negative. It's truly that you're not contagious. And I think that if we just did that all the time, you could stop forward flow. This is how the Olympic Village is doing it. They're doing daily rapids.
So if you were in charge of the world, how would you manage this daily testing? When you say do it all the time, what does that look like?
So I think the daily rapid test can be done by almost anybody, but I'm also a physician, so it's possible that I'm biased. But there are these home tests that are available. I think that if you did frequent rapid testing in a place where there's an outbreak, you could suppress that outbreak with relative ease because you know who's contagious exactly when. You can get those people to isolate sooner because the actionable information comes back in minutes, not hours or days. And actually, this may sound a little crazy, you can release them from isolation sooner because they're no longer contagious. If you got 2 in a row without symptoms, it's like, oh, wait, it's right in this shorter period of time. So we can ask people to do more for less time. So stay home, really do it. But then we promise to let you go sooner because you're not contagious anymore.
Okay, so let's get specific, talk about work and school. First, work. If I'm a business owner and I'm bringing people back in, but now Delta has hit and I'm not sure what to do, how could I deploy rapid testing to make sure my office can stay open?
With some kind of routine of twice a week testing, something to that nature. There's a little bit of epi statistics here where how often you have to do it will depend on a bunch of different factors. But I will say that, in a perfect world with infinite money, everyone should be tested every day. Why not? And because it's just, why not? But I think that in a world where the tests are $5-10 a piece, even in bulk, and there's just some degree of compliance, I think that twice a week testing, the latest data I've seen, can really make a huge dent in this. So I'd be having everyone do rapid tests, either self-administered or administered at the office twice a week until you're in a green zone.
And then should they mask at work, or once you've been tested, you don't need to mask?
Honestly, this is going to be controversial, right? But I think that if you're vaccinated and you have a negative rapid antigen test, the likelihood that you are a menace to anybody while asymptomatic is pretty nil. We cannot ever get to zero risk, but I'm telling you, I don't feel too badly about this. And I'll be honest, I went to a thing where it was thousands of people were there. This was a couple of weeks ago. They weren't masked. I was like, all right, it's fine. I'll just do it. And then I came here to California where, I interact with someone who's got immune compromised, and I had to test myself a couple of times and just to make sure that I'm not really doing bad. But I know that vax plus negative rapid, I feel like, look, it's as close to zero as we're going to get, folks.
Okay. Let's talk about school, where it's a little more complicated. The trials to bring vaccines to kids under 12 are not complete yet, and that means about half of school-age population is going to go back to school unvaccinated. That means that despite mitigation measures, there's likely to be some outbreaks. How do you think schools should manage this, and how should daily tests look in that environment?
So in a non-vaccinated area or an insufficiently vaccinated area, you can test your way out of almost anything. And it's just a matter of how much money and resources and willingness you have. An absolutely amazing study from China from last year, they had an outbreak in Shandong, and they actually did millions and millions of tests in about 5 days, and they never really had to do a big shutdown, and they suppressed an outbreak. It was just incredible. And this is in the New England Journal of Medicine. My eyes just bugged out. It was just like, great. And that was PCR. We could even do better now with rapids. So I think that if you don't have high vaccination rates, test. The false negatives are super unlikely for the contagious piece, especially with doing more than one test. You do like a test every couple of days. And by the way, the false positive, I know there's all these people are going to say, oh, if you test in a low viral area, the only thing you're going to have is these false positives, and everyone's going to shut down shut down schools just because of a false positive. And to that, I say, yeah, again, look back to the Olympic Village. When they have a positive on a rapid test, they immediately follow it up with a repeat. And if they have a negative that's low, that's no symptoms, then they might do it a day or two later. If it's negative with like extremely likelihood that they're in that window, then they just keep testing. It's sort of, you have to use your brain. So I think that you can absolutely use testing to keep schools open, and to use repeat testing to make sure you don't close too soon.
And is that also twice a week testing? Or are you thinking you do everyday testing for schools?
But this is not based on any evidence or modeling that I've done. It's based on looking at data that other people have done. And so, for example, in this hospital study they looked at daily testing versus every other day versus 3 days. And every 3 days seemed to be fine in terms of picking up the infections during the contagious period. However, it really could change depending on how many cases are on the ground. So I would just say you've got to have a protocol.
Okay. Let's talk about exposure at school, because you have kids who are unvaccinated. There's likely to be some exposure and a need for quarantine. So if kids under 12 who are unvaccinated are exposed to somebody who's infectious, presumably they have to quarantine. But what about the kids over 12? Like, if vaccinated kids at school are exposed to somebody infectious, should they also have to quarantine?
So I think in the pre-Delta era, CDC was saying that the over 12s vaccinated wouldn't have to. I think in the post-Delta era, they're saying that 3 to 5 days after a really known, pretty hardcore exposure, not like you walked within 5 feet of someone for 10 seconds, but actual 10, 15 minutes. The CDC wants even vaccinated people to get a test at 3 to 5 days to make sure. And the question is, what do they do until then? And I would say probably they're saying quarantine. The truth of the matter is there's a little window in the beginning where you can't even be contagious yet. So you could have a day, but I think that messaging gets lost. The younger kids, it's just the same way as it was last year. It's, if there's exposure, they've got to isolate, they've got to quarantine, which means stick away from everybody. And the CDC says 10 days. I really truly believe that if you have a couple of negative rapids and they're asymptomatic after 5, 6, 7 days, that you can get them back sooner. So I think it's a combination of quarantine and testing to shorten that window.
I'm asking you this because you have such an engaged mind. You do not have to have the answers to all the questions. I'm just curious, if we roll out all this testing, who do you think pays for this? Is that something is that a bill the government foots, or do we need billionaires to come together and form some consortium to fund it for the country? I mean, that gets expensive, doesn't it?
Yeah, this is the thing you read before, that there's no dollar better spent on testing. I do not foresee a moment in the near future where it's not worth it to have somebody pay for it, including the government. So you can run the math and say, what was the stimulus package? What did it do? Who does it reach? How does that work? And to me, because testing actually limits outbreaks, think of the savings that are there. It's just unbelievable. So we actually ran the numbers for Tokyo, and before they even had announced they're doing daily rapids, and Michael Minna and I just kind of crunched it. We're like, look, for 0.1% of the budget they've already spent on the Tokyo Games, they could rapid test everybody and save the Olympics. That's what they did. And so basically they determined that it was worth just that expenditure. And you can kind of run the numbers. It's like $5-10 a piece. There's 300 million people in the country, test them a couple times a week, and then realize, wow, how many outbreaks do we have to stop to actually make that worth it in terms of human life, economics? And the answer is it's very strongly in favor of just pay now. It's a down payment on the future.
So let's talk about the future. There have been a number of experts predicting that this Delta surge will peak and end within 6 to 8 weeks. And they base that on what happened in India and in the UK. Can you explain, do you know why it went so fast in India? And are those relevant to the US? Because, for example, in the UK, they were on lockdown when Delta raced through that community.
Right. So this is the earlier thing about how actually probably there's a small number of people who are responsible for most of the spread. The problem is you can never know who they are. And I think India came back off the brink sooner than I think people were worried. But I don't think that has anything to do with the virus. I think that has to do with us. In other words, that could happen again in India. And what I've seen over and over again with this virus, whether it's Delta or previously, is this sort of feedback loop, which is that, okay, cases go up, hospitalizations go up, everyone reads about it in the news, they know someone who got it, they know someone who had a terrible outcome, and they take it seriously and they stay home and they mitigate and they wear masks and they cancel their plans. And then after Christmas, right, you had the spike and then it came down, right? Just like we said it would. And then we got the vaccine on board and we loosened up. And then you loosen up and cases go back up again. So it's this feedback loop of our behavior. It's not just the virus, right? The reproduction number, this R number, is something that is in the virus, and it's something that's about us and what we do. So I think that the reason that we keep on having kind of shorter waves is that we start behaving ourselves. And so what that means is that Delta may not be done in India. It could swarm back if a handful of super spreaders or thousands of super spreaders are in the wrong place. So I think that going forward, you just see waves of various sizes and peaks depending on idiosyncratic randomness and depending on mitigation and depending on rates of vaccination.
One of the questions I get asked a lot is, we're always told that the US isn't doing enough genomic testing, like they're not sampling to see what variants are circulating where. And so people ask me, how do we know that it's Delta that's circulating and not something else? Do we?
We don't. I think that it's sort of like the way people who are like fishermen, what do we call them? Like they survey like small areas and they say, okay, based on that, we extrapolate. So yes, we need to do more of this. This is not an area that I follow very closely, but what I'll tell you is that one great thing about testing genomics and sequencing is you can actually kind of track things better, right? You can say, oh, this is one outbreak. I'm quite convinced that many of the outbreaks we had early in the pandemic were not just one thing, right? You heard about like the Biogen outbreak and that spread out. Yeah, but there are probably also like 4 other people in the community who had it and their spread kind of overlapped. And pretty soon you've got this sort of overlapping spider webs. And so genomic testing helps you track stuff. And I think it helps you identify new variants of concern. But I think overall for me as sort of like a population person, what really gets my eye is what's going on with the hospitalizations. Because if there's a spike in hospitalizations, there's not much else we could do except to say, okay, wait, we got to slow down. We got to close certain things or mask more. So I kind of track that, but it helps us know about an epi way, but not necessarily in a behavior way.
Okay, can you help with this one? I'm starting to get asked, well, if the vaccinated can spread Delta, Why do we all blame the unvaccinated for propagating this disease or creating an environment for more mutations to emerge? Would you answer that?
Yes, great question. The short answer is that the unvaccinated currently make up this huge portion of the pie chart, and we're back to flattening the curve. There are enough people who are not vaccinated in enough areas that we could actually surrender human life because there are too many cases at once. And I don't care what happens, the vaccinated cannot cause that to happen. There can be an uptick in hospitalizations in Delta breakthrough among the vaccinated, but there's just it's just the vaccine's too good for us to cause a spike that would actually cause an issue where we had to flatten the curve to keep the hospitals from overflowing. The unvaccinated, there are enough of them in tight enough places where they can do that to hospitals, and that's really a tragedy because those were surrendering like lives and care. The other piece is that yes, we are always in a race against time. So the unvaccinated are spreading this more quickly, which means there are more cases, more hospitalizations, which means we have to shut down, which is the very thing they don't want to do. It's ironic, right? It does give a breeding ground for mutations, which, God, Delta's bad enough. We don't need another one. And we're always learning, right? I mean, we just learned this past couple of weeks, there are a couple of small changes in management for doctors like me to say, oh, the patient comes in with hospitalizable corona, we should give them this treatment. It'll make a 5% difference, or, things like that. There's going to be new data this week. I can't say what it's about. It's going to make another small little difference, in terms of how we treat people. And I think that, it might be 5% or 3%, but 3% of 300 million is a lot, right? So slowing this down actually has a benefit because we're getting better at managing this disease in little increments.
I don't know the answer to the question I'm about to ask. Is there a greater chance for a dangerous mutation in an unvaccinated person than a vaccinated person who gets it?
I believe the answer to that is yes, and I'll tell you why. It comes down to viral load. So in pre-Delta, it was like by far it was worse. The unvaccinated were a breeding ground for mutations, because the vaccinated had fewer infectious for less period of time, and the viral loads were lower, which means fewer photocopies. And the more photocopies that are being made of this virus, the more mutations come out. So that was the sort of pre-Delta. Now with Delta, it's like, well, the viral loads are the same. So I guess the photocopies are, at the same rate, except what I just said a few minutes ago, which is that we think, or we're now seeing that Delta is maybe those viral loads are elevated for less time. So yes, it's not as good as it was before, but still the unvaccinated are the perfect breeding ground for mutations. The vaccine has majorly improving the situation for Delta by virtue of fewer infections, less time with the high viral loads. So I think that it's likely that it's still doing its job, but not as well as it was.
And when this much of our population remains unvaccinated, don't you foresee more variants developing, and who knows what kind of dangerous variant there could be out there?
Yes, that's true. One thing about variants is that they have different things. It could be more contagious, it could be deadlier, it could be faster, it could be slower. And depending on the environment, each of those things could actually make things better or worse. I'll give you a kind of a surprising example. Ebola is so freaking deadly, and it's contagious over such a tight little window that it's actually like relatively easier to shut it down compared to HIV, which takes years to kill somebody and they could go out and infect people. So it's always these like, well, maybe in this situation, this mutation could make it worse, but actually it could outcompete a different mutation, so you start to play this sort of different parameters. And so, yeah, the one thing about Delta is it's fast as hell. It moves so quickly, but it is not 10 times more lethal. And so sometimes I think, Delta is bad enough, and maybe Delta will just like kind of outcompete other bad variants. And in a way, Delta could be like, not good, but wow. It has an advantage, which is that it's outcompeting a lot of other ones. And maybe it's outcompeting one that's super dangerous.
Interesting. Okay, I want to ask you, may I take a few more minutes of your time?
Yeah.
I have some audience questions. You touched on this earlier, but are you in favor of a third booster shot, not just for the elderly and the immunocompromised, but for everyone?
Not yet. I think that I would say that the data I see is compelling for immune compromised individuals. It's compelling. It's getting towards compelling for older folks. And the reason I say that is that I believe it when I hear in places like Israel that they see an increase in hospitalizations among elderly vaccinated. That bothers me. So I think that that's worth doing. I think that it's a very probably for middle-aged adults, which or non-kids, that's a place where I'd say, well, we have to see. We have to see what the correlation is. Yeah, so there's waning immunity. Your antibody levels are lower, but like, does that mean anything? Does that mean that you're just going to get sick for 5 days? Does that mean the hospitalization risk is high? I think that we need to study that in the kind of non-geriatric adults. Is how I would describe the group we need to study. The group, then the real tricky one is the kids. This is really hard because, okay, on one hand, this virus is actually not good for kids. I can't stand it when people say, oh, let's open schools because it's not bad for kids. That's just completely inaccurate. You can open schools and acknowledge that actually it's still, it's relatively rare compared to like the fact that 10% of our grandparents are like, crapping out. But like, it's so much better for kids. But if you actually do the math, like thousands of hospitalizations, hundreds of deaths, it's completely inappropriate for kids to be dying of an infectious disease in today's day and age, right? So, but then the problem is the side effect profile. So I wrote a piece that was in the New York Times. And what I did was with Celine Gounder and Katie Dixon-Mays is we did kind of a sort of like thought experiment. Like, what if we vaccinate every kid? And what if we let every kid get coronavirus? Because those are the two options in the end. That's it. And let's follow their hospitalizations out. So we kind of follow that out. And in the pre-Delta era, it was like not close. It was like vaccinate them all because there's going to be hospitalizations on both sides, myocarditis, whatever else. But the COVID hospitalizations are much more common. They're much worse in outcomes, everything. However, what I don't know is what would a third dose do to a kid in terms of the side effect profile? I can't imagine the third dose would affect adults in a bad way that isn't immediately negated by the insane level of hospitalizations and deaths that come from this virus in most adults. But it's possible in kids that that's not true. The triple kind of pump fake is that some people are saying, oh, we should just only have one dose for kids. Delta renders that idea pretty foolish. I mean, one dose of Delta is not enough. We see that. 2 doses seems to be good, but it comes with this risk benefit. What my question is, at 3, where would we be? I would want to study that.
Okay. Then people who got the Johnson & Johnson vaccine are asking, should they go for 1 shot of the mRNA vaccine? Should they go for 2 shots of the mRNA vaccine?
Yeah, I don't have the answer to that question. I think that it's reasonable to have that discussion. A few months ago, I did not think it was because it was keeping everyone out of the hospital. And I just didn't feel like it mattered that it was like a little less efficacious on mild disease. We're trying to fight a pandemic, not like, have a few less sick days. Now it's a question of what the data show coming forward. And it's funny, we talk about this now, but there could be a variant in the fall where suddenly the Pfizer folks are like, oh, can I get the Johnson & Johnson on top? Like you don't know what's going to happen. So open question. Before my answer was no. Now my answer is I'm not sure.
I know you're not supposed to advise this, but I have friends who've gotten Moderna or Pfizer and they want to sneak into a place and get a 3rd shot. They don't need it. Yeah. Like it's
the average person I don't think needs it. I think that if you are someone who has an organ transplant and you take immune suppression drugs, if you're someone who the CDC looks at like you're on these what they call biologics that suppress your immune system, I think those folks should get it. And it's funny because in some places they can't because it's not quote unquote approved. And I'll tell you, I've told those folks like, you didn't hear it from me, but you might want to consider it. But that's the very, very rare sort of case.
Okay, I have so many. Can we do some quick ones? There's a medicine called ivermectin.
Ivermectin.
How do you say it?
Ivermectin.
Okay, I did a terrible job. So it's circulating in the anti-vax crowd that it seems like it's the new hydroxychloroquine. This is the miracle. Can you speak to what is that and why should it not take the place of getting a vaccination?
Yes, ivermectin is unfortunately not going to change this disease process. It's not going to bend the curve the way people want it to. It's not going to end this thing. If there is a small subpopulation of people who benefit from it, I welcome that news, and we'll see what happens with them. But it'll be an incremental thing if it's there. What's strange is that people can't seem to get their mind around that. They're convinced that it's like this, literally panacea, like this cure-all, right? And it's just based on hope, optimism, and this strange sort of. It's weird. It's like the same people who deny the severity of the whole thing think that this is like the way out of it. It's a strange cross overlap. Ivermectin is an anti-parasitic medication. It's great if you got worms. And it's been studied a bunch. So far, nothing important has really been found. Let me tell people this. Doctors like me could have my career could be like ensconced in gold, and they'd put me on like the medical Mount Rushmore if I were to run a trial that showed that ivermectin made a huge difference. Like, I would love to be that guy. And, my family would be proud of me, and I saved millions of lives. Doctors who study therapeutics want victories, and they want to be the one to discover it. And the fact that we're not, the fact that Merck, who makes ivermectin, basically said like, sorry, this is just not worthwhile. That ought to tell people something, because there's always this narrative of like, oh, here's the thing that doctors don't want you to know. And it's like, are you kidding me? Like, I would love a Nobel Prize. Like, let me do it. But people are out there studying it, and unfortunately, the data have been basically another throwaway. But people clung to it, and the reasons for that I'll never understand.
That was a very persuasive answer. Thank you. Should vaccinated people think twice about traveling in the fall and winter?
Yes, fall and winter is too far away to make any plans. So unfortunately, my approach to this is refundable tickets. Is all plans are soft until the day of or whatever. And I do believe that the extent to the change we have to make will have a lot to do with the virus and what we do. But I still come back to this. If we just decided to test a bunch more, we could maybe get around canceling a lot of things.
Are you against traveling in August, or does it really depend where you're going and what the infection rates are there?
Yeah, I think it depends on what's going on. Look, again, I just said that we should emulate the Tokyo Olympics. Like, if people are going to do stuff, they should do stuff safely. So beforehand, what kind of masks, that kind of thing. Now I'm definitely double masking on the plane or in the airport. Actually, the plane's funny. The plane's so safe because there's such good air filtration, and it's vertical, so you never hear about outbreaks on planes. Whereas in like conference halls, it's like very horizontal, and they share. So double masking, testing more.
Okay, this is a big one. Why is it taking so long for the FDA to approve the vaccine for kids under 12? Parents are asking.
I don't know the answer to that, except that they tend to move with the data they have available. And this is actually super interesting because it actually answers one of the questions from last year. One of the most common questions is, how come it was so fast? They cut corners, right? And the answer was that one of the barriers in vaccine research are willing participants, which in a normal situation, no one's like lining up to like try for a vaccine that what disease is that? Like, I never heard of it. Why would you test that on me? Last year, everyone's like, oh, you have a coronavirus vaccine, possibly? Sure, put it in my arm. So there was willingness. And this is the one upside of our stupid response that had such out of control spread. We got a signal so fast, right? If you need 30,000 cases to differentiate how the placebo does from the vaccine, and it takes you a year and a half to get 30,000 cases, you're not going to have data for a year and a half. If you get that data in 4 months, you're done. So we got that data quickly because we're such idiots and we let the thing spread. So in a weird way, there's some magic number, right? With kids, it's I don't know what's going on in the trials, but it's very possible that because of the vaccinations, we slowed down infections. School was out for the summer.
Myocarditis too, right?
Pardon?
There's the concern about myocarditis. Right.
So some people aren't so psyched to enroll their kids, right? But I think that one of the things that probably has happened is that the rate of infection has gone down overall. And so it takes you longer to get a signal that you can then go to the FDA and say, hey, look, we've got 10,000 kids with placebo and 10,000 kids without, and here's what we saw. They're like, well, we don't have 10,000 yet because we actually slowed this thing down for a while, which is good, but it just means it delayed some data. That's my likely guess on what's going on there.
Okay, couple, there's a lot of questions about infants at daycare. Is my 5-year-old baby more at risk with Delta? What can parents do to keep the kids safe?
5 month old. I don't know the answer to that. I have not seen studies that look at like infectivity in infants. I don't know. Sorry.
Should pregnant women change their behavior if they're vaccinated now that Delta's around? No travel, stay home.
Interesting question. I have not thought about that. Well, the top line message is that it's more important than ever to get vaccinated if you're thinking about being pregnant. That's like a huge deal. The outcomes of COVID and pregnancy are like not happy. It's the maternal death rate in this country, like, it's really zero, but at baseline, it's like 1 in 25,000 pregnancies have a fatality, or 1 in 20,000 ought to be zero. As I recall, the risk of death in COVID and during maternity went up by like 25 or 30 times. It was like crazy high. You do not want to be COVID positive while giving birth. So that's the top line piece. Should pregnant people change their behaviors? You know, I don't necessarily think so. I don't know yet. It would, again, the protection is still there. Antibodies do transmit through the placenta. Amazing. The virus doesn't. The human body is an incredible place to be. Let me think about that. But my initial thing is it probably shouldn't change much, but I'm punting.
Okay. Do you, I forgot to ask this, should we be getting antibody tested? And is it possible to know once you're vaccinated from an antibody test whether you got COVID previously?
At the moment, I think antibody testing doesn't have a huge role to help us understand what's going on, unless you're someone if you're worried about being a non-responder. So if you are someone who's immune compromised, you need to know your titers and to see if those sort of match up to like expectations. For the rest of us, it's a curiosity shop. I mean, I kind of always wondered, like, I had a real fun time when I got vaccinated. Like, and by that I mean I had like complete what I called anaphylaxis. I was just like laid out, and I was like, wow, did I have like asymptomatic COVID and like I had antibodies, like, and I kind of wanted to get tested just to see. And then I kind of like, at the end, like, who cares? Like, I'm vaccinated now. So I don't think it changes much. I think over time, what matters is that researchers are following the waning numbers in the population. And so you can say, okay, you're, a 30-year-old female, you're a 50-year-old male, you're this far out from vaccination with this product. Based on the average person that we've studied, you do or do not need to change your behavior. You do or do not need to get a booster. That's why I think it's useful, but not in like a one-to-one basis.
Okay, this is a hard question, but I want to ask you, what will the future look like? But I'm going to use an audience question to ask it. Someone in my audience asked, will COVID ever end?
That's a great question. Did 1918 ever end? How did that end? We don't know. We have an idea, we think, but we really don't know. I think that this crisis that we are living through right now will not be with us forever. This level of just concern and death and disability and misery. Yes, we will get through that part of it. It's because these vaccines are great and we can actually make changes to that and all that. Is the virus here to stay? It's going to be endemic. Yeah, I think so. And then the question is, what percentage, what does herd immunity look like and how do we get there? When do we get there? It's funny, back in the day, Fauci said, he said in 2020, it's like, this is going to be a bad year. 2021 will be worse. And then maybe 2022, 2023, things will get back to normal. And I remember thinking, dude, like, that's so pessimistic. But, it's starting to look like he knew what he was talking about.
Wow. I want to end on a happy note. So 2022 is going to look more optimistic, right? Things will get better. I don't know, right?
I can end on an optimistic note. For one thing, the vaccines are so freaking good. It just blows me away. I never thought when we started this that we'd have something this good. And it's just incredible achievement. I'm just like, one of the best days of my life was the day that I read the first Moderna and Pfizer trial, and I had nothing to do with them, right? So that's that. Go us! Like, and we're going to end this pandemic in a human way. In other words, this pandemic is not going to burn out because it burns through us. We're gonna the state of emergency will be eliminated by our actions. That'll be on an acute pandemic. That'll be a first. And that'll be something that, we can be proud of. So we got to get there, but it's going to end because of our technology, our ingenuity, and our giving a damn.
Dr. Faust, you're such a wealth of knowledge and you're such a good communicator. Thank you. I want to tell people to follow you. I'll post your handles, and your newsletter is called Inside Medicine.
Yep, Inside Medicine on Bulletin, where I know you hang out. So we are, twice a week on Inside Medicine. I've written about Delta once. I'm writing about Delta right now, and but also other areas of medicine. Why the Olympics shouldn't be canceled, but they should be emulated. I did one about schools and how suicide rates actually surprised us. They went in the opposite direction we thought when schools closed. Suicide attempts went down. And so I just try to cover a lot of different things. Yeah, hope you guys will join me over there.
Yep, I'll post so people can find it. Thank you for your time.
Thank you.
Hi, I'm Jessica Yellin. If you like this video, please click subscribe, and you can click the bell to get notifications when we post new content. Thanks for watching.